Join Yvette Walker every Tuesday at 4 o'clock p.m. on KMET ABC News Radio, 1490 AM, FM 98.1, and Internet KMET TV for the Southern California Business Report. The show is dedicated to highlighting successful businesses and the individuals behind them. Yvette interviews the incredible people managing these enterprises that range from awe-inspiring sole proprietors to world-renowned organizations. The Southern California Business Report, Tuesdays at 4 o'clock p.m. Welcome to KMET 1490 AM ABC News Radio and the Southern California Business Report with Yvette Walker, a show dedicated to highlighting successful Southern California businesses and the people behind them.
Welcome and thank you for joining the Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV. I'm Yvette Walker, live, blasting our signal from the center of Southern California, serving a population of over 25 million. Get us crystal clear and on demand by downloading the free KMET live streaming app on Google Play or the Apple App Store. A huge shout out to the team, Mitch, Bill, and Sean, I love you. And to our special advisory committee, Bill Morris of UCI School of Business, Diane Cavallo, and Camila Rubio, thank you. Don't forget to check out the Jay Kaplan Show, also on KMET, on Fridays at 3. Today, I have the distinct privilege to introduce Dr. Samir Samarany of San Antonio Regional Hospital. He is dedicated to advanced cardiology care, the latest technology and updates on non-invasive procedures for common and rare cardiovascular conditions and treatment options. Dr. Samir Samarany is a cardiovascular specialist. He was born and raised in Lebanon and is trilingual in English, French, and Lebanese. He is a very thorough and caring physician and believes in the value of patient education. He also has a personal interest in information technology and electronic devices, and he is always looking for ways to utilize and improve patient care and medical practices. Outside of medicine, he enjoys spending time with his family, playing soccer, and exploring new places. He has 2 daughters, Chloe and Zoe, and is married to a lovely French woman, Danielle, who carries a major in interior architecture. His clinical interests and experience include evaluation and advanced treatment of structural heart disease with non-surgical interventions, TAVR, mitral clip, tricuspid clip, TMVR, Watchman device, valve-in-valve, PFO closure, evaluation and treatment of peripheral arterial disease, chronic venous insufficiency and veno-occlusive disease, and evaluation and treatment of pulmonary hypertension. Dr. Samarany has a strong background in care management and treatment, including advanced therapies of heart failure. He is a specialist in cardiac CT, cardiac MRI, echocardiogram 2D, 3D, nuclear imaging, and vascular imaging. Dr. Samarany's training includes advanced cardiac imaging at Yale University Hospital in New Haven, a cardiology fellowship at Yale University Hospital, an internal medicine residency and chief residency at St. Raphael Hospital in New Haven, and medical school at Lebanese University in Beirut, Lebanon. Thank you so much for joining us today, Dr. Samarany.
Thank you, and thank you for that great introduction. Thank you.
Well, you have such a tremendous background in technology, cardiology, and heart health. And please share with us and our listeners and our viewers your journey to becoming the cardiologist in the position that you are today.
So it's a long story, but we'll make it short for sure. So the thing is, like as any doctor, usually you have like that science motivation to do and know science more. And always there is like always a personal experience that push you, that you want to help people and use that science to help people. And everybody, I think most doctors I think share the same experience. So for me, I think it was my close friend, I think was unfortunately has a very rare disease called Duchenne disease that affects you slowly when you grow up, and you cannot walk slowly, and your heart will be affected at age 30. And unfortunately, most people don't survive. So being very close and a cousin and a family member, and being into science since when I was at that age, so I decided like to continue that route, especially focusing on cardiology and rare disease, because I see those people struggle a lot to find the right care or people who know that rare stuff. So plus the technology kind of that I like, and I combine those both worlds to go into multiple advanced imaging, which is mainly based on technology to help people in multiple disease and rare disease. So I started, as you mentioned, in New Haven, in St. Raphael, chief resident teaching, and then I went to Yale, and Yale offered a lot of options in that regard with research capacity, and I was able to reach my goals in that level. And I want to use all that I learned to help the community here that I'm.
Well, thank you so much for channeling that unfortunate experience into a very positive direction. And now you have the opportunity to help so many. So before we get into the real, technological stuff, let's talk about, in general terms, heart disease, right? Can we talk a little bit about how we can prevent heart disease, and maybe talk a little bit about how heart disease looks different in men and women?
Oh, yeah, definitely. So that's great questions. So preventing heart disease mainly rely on lifestyle. And people sometimes hear that word lifestyle changes, but there is a lot of details to support that. If we divide it into multiple kind of sections, so mainly if we start by diet. So diet is a big role, especially the cholesterol and the fat diet that lead to that number one killer in the United States and the world. And that diet is very key. Now, a lot of data has done, mostly observational. I mean by observational, meaning there is not like just you watch what to see, but there is no like kind of randomization or kind of standardization. So, but the one big study, primate study, was done in Spain and Mediterranean plus United States that showed Mediterranean diet, and another study in United States DASH diet showed that decreased blood pressure, decreased heart attack, and decreased mortality. So that's the first step. So first step is the salt and the fat are a big kind of player unfortunately in our diet. Second, our exercise. As much as you exercise, I tell my patients even at 90-year-old, some of them do exercises as much as their age kind of support or age or their body age support. But any exercise is very important to continue that support for heart health. And that's simple changes in your life that allow you to be kind of avoid heart attack. Now, in other cities, especially here in California and other, pollution has played a big role. If you look into demographics, people who live in where pollution is high, heart attack and heart disease are high. So they go along also. So that's also very important to know. People sometimes don't know that it's related. But it's a combination of multiple things. And I focus a lot also and I did the research at Yale about it, regarding mental stress. So mental stress has a big role. Even we did a study that we induce mental stress, but knowing the people, and then we check the vessels for plaques, and the plaque size has increased after mental stress. So being out of stress, which is hard, and doing like all these therapies to be able to decrease the stress in your life, plus the things that I mentioned with exercise and diet and avoiding pollutions are a big combination to decrease heart disease in the world. Now, there is new technologies, which we'll talk later on. I will not dwell into that we can now predict the possibility of you having a heart attack in the future. Before we didn't have it. One of them called calcium score, that we can do it on a CAT scan, a simple CAT scan for 5 minutes. But we can know how much plaque have built up already and what's your calcium, all the plaque, meaning the calcium or calcify the plaque. We'll talk about it a little bit about how we can prevent and tell a person what's your risk to have a heart attack.
Wow, that is tremendous. So in terms of exercise, what do you think is a good standard exercise regimen? Is it 2-3 times a week, 30 minutes? Is it every day? What is it that you recommend?
The American College of Cardiology recommend at least an hour of aerobic exercise, at least 5 days a week. We prefer more, but at least 1 hour aerobic exercise a day. If you can do more, it's better. And that's kind of a fast walk, doing like your bike. So that's very important. That's very important for the heart health rather than sitting and gaining weight. So that's very important.
Okay, so let's jump into the amazing technology that you're working with to repair heart valves and treat patients in more non-invasive ways. So can you talk about the technology that can repair heart valves today without an open procedure?
Definitely. So that era, I think it's growing, and it will grow even more in the coming 10 years. All the expectation for that kind of section in cardiology to grow, because unfortunately in the old days, when you're older, let's say older, we define it, let's say 75 and above, you go to a surgeon and you have a valve problem, you go to your primary care, he sends you to a specialist, then the specialist diagnose it, let's say with an old ultrasound or an echo, and then send you to a surgeon. So the surgeon, unfortunately, it's based on his decision. He tells you your risk is high. Unfortunately, those people, that's it. So their mortality is high. Within 2-3 years, unfortunately, they don't survive. So for those people, like these people kind of that we didn't have any options before. Now we have these new technologies that we'll talk about in details. Now, the most common that began with the aortic valve. Aortic valve is, just for people to know, is the valve that lets the blood go out of your heart. It's made of 3 pieces, and that valve, unfortunately, get older. Some people get older early at age 50. They have genetic background. Some others, they start by age 80 and above, and they build up that calcium I talked about, and they make the leaflet very less mobile. And now the valve doesn't move, and there's no blood coming out of the heart, and you start feeling tired, fatigued, out of breath. So, and you don't survive within 5 years when the symptom starts. So now, for those people who are old and they still have a good functional capacity, they have no other disease, and they have kind of that valve limiting their life and limiting their survival, nowadays what we can do is, after assessing the valve with 3D, as you mentioned, with echo, we can, with CT also, CAT scan has a new technologies that we can size the valve. And then what we'll do is, there is new valves with multiple companies, that the valves, they're in a stent, and they're kind of crushed in a stent. And we go without cutting, we go through the groin, or most commonly, and we go up and we put that stent in the old valve. And now your old valve become your support of a new valve. And now you have a new valve without surgery next day home or same day, which is unbelievable. I think in the past, nobody would have done a valve surgery at the 1 day and discharge. So, but the key points to be successful in this, you need to use those technologies that I mentioned in 3D echo and CAT scan to size that valve, to catch the right valve, avoid complication, make sure it fits well. And then people survive as equal to surgery. They did the partner study, we call it, and series of partner trials. And they showed that even sometimes they're superior to surgery in even low risk patient, or equal. So that kind of, it's a breakthrough in the world of cardiology that people should know about.
Oh my goodness, that is tremendous. I mean, a procedure that was once open, to have it so, controlled and non-invasive, but to be able to provide a life-saving opportunity is absolutely tremendous. So I know you're also a hypertension specialist. So can you please share with us what exactly is pulmonary hypertension and what it is that you do to treat it?
So that's another section also that's also very important. Pulmonary hypertension is one of the most complex diseases that people unfortunately have. To let people know, pulmonary hypertension is pressure inside your lungs. Your lungs are not built to have high pressure. They're not. They're low pressure. Your body have a little bit high pressure, but the lungs are low pressure system. So when multiple conditions can rise the pressure in the lungs, and those people need a lot of kind of investigation, like you need to work a lot to see what the causes are. To summarize a little bit, we divide it into 5 causes. The one cause sometimes is your own body attacking your organs, meaning like rheumatoid arthritis or rheumatism or lupus, the people who knows those conditions. And with time, they attack your lungs vessels, and you have high pressure in the lungs. High pressure in the lungs will lead to the right side of the heart, which connected to the lungs, to be dilated, and you cannot even walk to the door with severe out of breath. So that's very kind of severe disease if you don't catch it. Sometimes diet medication, people run for losing weight and they use those diet medications. Some of them, phentermine is one of them. And that also can cause high pressure in the lungs, which is reversible. Even if you stop your medication, you're already doomed with that, unfortunately, pressure. Second is heart disease that can cause you the same. Third, sometimes a clot. People, sometimes you hear they had a clot in the lungs, But
Right.
20% of people, they don't clear their clot and they have pressure in the lungs. And the other stuff are rare lung disease and other disease that can cause pressure in the lungs. But those patients need a lot of care in multiple details. And I provide that multiple other heart doctors refer to me because I'm specialist in that domain to help those people at least have a life, able to walk, have the right medication. And there's a very tricky what to use. So it's a very tricky population that you need to be treating them like family members. And that's
right. And so in your experience, is this something you see more in men or women? And what are some of the symptoms that we should be aware of to seek help immediately?
So usually it depends on the cause of the disease. So sometimes if you go the cause of lupus, let's say, is more in women, but if you cause other causes like clots, is kind of in the equal range. But it all differ based on the cause of your condition, the disease that caused you the pressure in the lungs. But the main issue is to do medication to decrease that pressure. And we go measure the pressure also inside the lungs to be accurate and follow up with these patients. And then also some people unfortunately don't respond and they end up with a lung transplant and those kind of conditions. Now, there is also a very interesting case that I should mention. Sometimes rare disease, as we mentioned, like a hole in the heart. I had a patient who was born with the hole in the heart and has been having problem with breathing, and everybody telling her that your pressure in the lungs is due to your COPD or lung disease, until she sees me at age 70. At age 70, through those 3D technology and 3D echo, I was able to find that she has a large hole in the heart that she's born with. For 70 years, nobody noticed, and her twin sister even died from the same condition, and they found out on autopsy later. But she was lucky, to have it on time, and then we diagnosed it, closed the hole with the condition without surgery, and treat her pressure, and she's now off oxygen. So you need to be very thorough with those kind of patients that you provide pulmonary hypertension treatment.
And so as of today, Dr. Samarany, can you talk about the technology and the techniques that you use to treat pulmonary hypertension?
Yeah, definitely. So pulmonary hypertension has grew a lot in the last 10 years, mainly with the type of medication that you use. Now with the new research coming, now we have multiple pathways we call, where we can target those vessels that causing the pressure in the lungs to relax and be less pressure in the lungs. Measuring how to measure the pressure in lungs, there is a technique also to measure, and specific technique that we launched here also in San Antonio with the program for pulmonary hypertension. Now also the other workup for the heart that include all the advanced in technologies that I mentioned. 3D echo plays a big role to find those congenital heart disease, hole in the heart, or malformation in the heart that will lead to pulmonary hypertension. And that's kind of and ability even right now to be able to remove the clot in the lungs and get you better without only giving you blood thinner. In the old days, we give you only blood thinner. So all these technologies combined let you have a successful pulmonary hypertension program.
Wow, that is phenomenal. So can you share with us, just, for everyone, right? When do you recommend for all of us to come in and just get a baseline understanding and reading of our heart function and where it is in terms of health? Do you recommend that for everyone? Do you recommend it for people that are in high risk groups? Or what are your recommendations?
So the recommendation mainly is based on the risk profile, as you mentioned. So you hit the nail on the head. So the mainly, let's say we start young people who family history of early heart attack. Families, they have heart attack, father at age 40 or mother at age 35. So that's very young. Those people for sure need to come to see if they have that genetic background that may predispose them to early heart attack, and nobody knows that this age group can have a heart attack. So with these people, sometimes we do, as I mentioned, that calcium score or CT coronary, which is a new technology that we can see your vessels and the plaque and how much plaque you have without going invasively, without going with the needle or inside. So we can see everything inside and how much you have burden to tell you, you're high risk. Now, that's one part of the people that should come. The second are people who have risk factors. The risk factors well known for heart conditions are cholesterol problem, diabetes with sugar, the blood pressure, obesity, unfortunately, and non-exercise, as we mentioned, and sometimes early menopause in women that predispose them to, and smoking, for sure. A big one is smoking. So that's kind of, these people for sure need to, if they have one or all of the 5 I mentioned, they need to present to a cardiologist to have that prevention medicine. Right now, there is preventive cardiology medicine with tools, with blood tests, specific cholesterol molecules that we check, not the regular ones. So to know your risk in detail. So we know more data now, how the body create those plaques and cause you the heart attack compared to before. So we use those tools to be able to help you prevent a disaster in the future.
Right. And so what preventative measures do you offer your patients to reduce or eliminate the plaque that is building up in their hearts?
Definitely. So nowadays, right now, we have much more cholesterol treatment, let's say. Those plaques are made of cholesterol. There is 2 bad molecules that people should know about and always ask their doctors about. One is called LDL, or low density lipoprotein. That's usually, we call it the bad cholesterol. And there is another one called lipoprotein little a that also hit people at young age and cause them to have that fat buildup inside the vessels, either a stroke or a heart attack. So when we catch those kind of people, or genetic testing that we know they carry the genes, now we can know the gene that you carry that predispose you to heart attack, a couple of genes. So in those people, we offer multiple other treatments other than the lifestyle and the statins that all people have. Right now, we have injectables that use that only like precise medicine. It's an antibody that goes without side effects and hit where the cholesterol is and drop your cholesterol by 50 to 60%, which we never seen in the past. And when we get those cholesterol numbers, the 2 molecules I mentioned, to below 50s, your plaques becomes to regress. Before, people think like asking same questions, if I have a plaque, that's it for me, or it can regress. Cholesterol is the big player in that regression. And if we're able to get it to very, very low numbers, that disease will regress. But you need those tools that they're new, and then you need to know when to use them and how to use them. So we're more going to precise medicine and get you less heart attacks in the future. And that's very important.
That's wonderful. So is that along the lines of genetic therapy, or kind of like pharmacogenomics in terms of more direct medicines that are geared to specific genetic types?
That's true. So mostly right now, there's like in the past 3-4 years, there was big articles about precise medicine and coming in the coming 10 years. So we're heading with all medicine into precise medicine. Precise medicine meaning you target the pathway and the molecule without causing other organs to have side effects or affect them. Unfortunately, some of the medication we use now, they affect multiple organs. You use them for something, but they cause something else in other place. But precise medicine with antibody and direct effect medications are, I think, the future into cardiology and all internal medicine. Plus genetic, we're not yet with genetic. We have some genetic tools, they're not yet powerful to know which medication works on you. So we offer that also in my practice, but we're not yet into the most cover all diseases, but some diseases now we know a little bit more genetic precise medicine with.
Wonderful. And so in your practice, what are the more specific and aggravating heart conditions that it is that you cover?
So mainly, I see a lot of people who have, other than the pulmonary hypertension that we talked about, I see people who have heart failure, and other than also the blockages in the vessel or coronary artery disease. So heart failure is also a big player leading to mortality in the United States. But heart failure, you need to be very thorough and know what caused you heart failure. 50% most of the time are blockages in the vessel, but there is another 50%. And there is one condition, what we call it stiff heart syndrome, which I see it a lot in women, especially more than men, age 50 and above, or with increased weight and diabetes and hypertension. Those people, unfortunately, women, they end up to have a stiff heart, and people sometimes get undiagnosed or go to their doctor and they don't know they have heart failure. Because when you do your ultrasound, they tell you your heart is working well. But the problem with that heart is that it doesn't relax well. So that as bad as when your heart doesn't work, because imagine a chamber. If it doesn't open, you don't have enough blood for you to pump, even if your chamber is working well, but it's very small. So those conditions are very hard to treat. Until nowadays, we have a breakthrough medication in the past 1-2 years only. But in the past, all these people, unfortunately, suffer a lot and need to be on a lot of medications and not improving except just treating their symptoms. Until nowadays, we have a breakthrough medication for that condition. But that's the most common kind of the CAD, which is the coronary artery disease, the heart failure, the two types, the stiff and the weakness in the heart, and the valve problem. Those are the most common things I see the most, and I go through in details with the technologies I talked about.
Wow. Thank you so much for that, Dr. Samarany. For those listening, I'm Yvette Walker on Southern California Business Report on ABC News and Talks KMET 1490 AM, 98.1 FM, and KMET TV, talking to Dr. Samir Samarany of San Antonio Regional Hospital. He's dedicated to advanced cardiology care, the latest technology, and updates on non-invasive procedures for common and rare cardiovascular conditions and treatment options when we return.
City of Hope is driven to making a difference in the lives of people with cancer and diabetes. We accomplish this by conducting innovative research and providing outstanding care. If you or a loved one has received a cancer diagnosis, go to cityofhope.org to learn more about how our innovative approach could change your outcome.
The University of Laverne is rated first in California for alumni satisfaction. Learn more about accelerated programs offered online and on campus in Laverne, Irvine, Ontario, Burbank, or College of the Canyons. Visit go.laverne.edu. The University of Laverne. go.laverne.edu.
Every 2 seconds, someone needs a blood transfusion. Be on the giving side. Livestream Blood Bank supports patients in 80 Southern California hospitals. Call 1-800-TRY-GIVING for more information and to set an appointment.
Ontario International Airport is on to a better way to fly with over 65 daily non-stop flights to more than 20 major destinations and the easiest airport experience in Southern California. Visit flyonto.com/Ontario to learn more about Ontario International Airport today.
Welcome back. For those listening, I'm Yvette Walker on Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV, talking to Dr. Samir Samarany of San Antonio Regional Hospital. He's dedicated to advanced cardiology care, the latest technology, and updates on non-invasive procedures for common and rare cardiovascular treatment options. Thank you again for being here with us, Dr. Samarany.
No, thank you. Thank you.
So thank you. So before the break, we were talking about general cardiovascular care and the treatment options that you offer your patients. And right now we're going to go into the more rare diseases that you treat. And one of those is dysautonomia.
Yes,
so
dysautonomia.
Dysautonomia is
you got it right.
disease, and it's a very difficult one for me to pronounce, but please share with us what it is and what the treatment options are for this rare disease.
So I was fortunate here in the area that there is a primary care that's specialized in that field, and that field, to explain to you in details, some young people, unfortunately, that suffer from that condition, 20 to 40 years old, most commonly, and they already went to multiple doctors, multiple other specialists, and nobody knows what's going on. So it's a rare disease. We call it hypermobility joint syndrome, and it specifies multiple other types, meaning your joints are very lax, plus it affects your nerves. There is one condition called Ehlers-Danlos syndrome, and there's societies for it. And there's multiple types of it. And one of the types is called type 3 that affects, unfortunately, your nerves and vessels. So what I mean by dysautonomia, our body have nerves that tells us what the blood pressure should be when I stand up, what the blood pressure should be when I sleep, what the heart rate should be when I stand up. In those people, unfortunately, they don't have a system that works well. So they stand up, their heart rate goes to 150. Their brain is foggy. They feel sweaty. They feel they're going to faint. They feel upset stomach, that also sometimes their body attacks them from a lot of allergies with that condition. So they faint multiple times, like sometimes dangerous while driving, they didn't know they have that condition, or they end up with a big accident. So dysautonomia, as simple as your body is dysfunctional by working up your blood pressure and heart rate. And there's multiple types. One of the famous types, it's called POTS. POTS is postural orthostatic tachycardia syndrome, meaning every time I stand up, my heart rate goes super fast, and I can be severely dizzy, severely out of breath, and cannot function, completely cannot function. Being out of school, cannot do my work. So those people need to have this specific diagnosis. We do a couple of testing called tilt table test, and we follow with the primary that's specialized with that condition, and us as a cardiology, to follow those people to be on the right treatment, to diagnose what type they need to be and what they need to avoid. Sometimes, to give you an example, if they have a hot shower, they faint. Sometimes if they eat large meal, they faint. So those conditions, they have a specific recommendation not to do, and they need a specialized kind of specialist plus internal medicine specialist to help them in all the aspects of their condition. So we call it dysautonomia syndromes. Now those are you're born with, but there is others you get it later at age. So an example, sometimes after having diabetes, you can end up with that condition later on. Sometimes after an infection, you get a simple infection cold, and suddenly you start fainting after. So, or a GI upset, or a just GI infection or stomach infection. So that's the same thing. So these conditions need to be picked up and treated to make sure you have a lifestyle without fainting, which is a big deal.
Right. No, I absolutely agree. So is that a structural condition of the heart, or is that a chemical reaction the body?
It's a chemical reaction, if we can describe it this way, but it's a body reacting in the wrong way with what we call it neurotransmitters or hormonal transmitters, meaning how the body talk to each other. It's lacking of communication between the nerve and the organ. And that's what happens with multiple triggers that lead to it. And people may end up in the hospital multiple times and recently I had a patient who went to multiple emergency room and nobody knew how they don't know how to treat them. So unfortunately, they suffer a lot until you go to a specific center that treat dysautonomia.
And so what are the treatment options?
So the treatment options vary from multiple types of medication depending on the type of dysautonomia you have, and following carefully to know what you need to avoid in your lifestyle that may trigger that event. Plus drinking a lot of fluid and eating salt. That's the only time a cardiologist will tell you to eat salt. So usually we tell people not to eat salt except in these conditions. And there is also specific exercise with people, what they do, we call it muscle toning, to improve the muscles in your legs and arms to get your blood back to your heart and not have low blood pressure when you stand up. So there is a lot of, it's a big program for medication, muscle toning, avoiding the triggers, and following up in details with medication to get them to the lifestyle they want normal to live.
Right. And so what triggers have you seen that contribute to dysautonomia?
Yeah.
Dysautonomia.
So let's say the most common triggers, as I mentioned, dehydration, any cause of dehydration. You're losing fluid, bodily fluid, or you're in a hot area like here in California, let's say in summer, and you're sweating a lot and losing fluid. That's one of the triggers that you can faint. Second is a large meal. So these people, we tell them, instead of having 3 large meals like breakfast, lunch, and dinner, you have 6 very small portions, which helps them avoid that reaction after you eat, that the nerve will trigger that reaction. Hot shower, as we mentioned, standing for a long period of time. When they stand for a long period of time, their blood is not circulating as appropriately, and they drop their blood pressure and faint. So all of these triggers I discuss with my patients all the time to know what they cannot do and what will trigger their condition.
Wow, that's remarkable. And how many patients on average do you see with this condition?
So usually, because I'm specialized in this, I see a lot coming. So usually an average kind of in a daily, if in the clinic, on a day, I see 2 to 3 in the clinic, with the average in a week reaching like 20, sometimes less, so depends. But it's more because I'm specialized in that condition, so they come to that place with the right kind of referral. But I think in a general prevalence is not as prevalent, but it exists, and unfortunately is not treated well unless you channel with the right programs and pathways.
Wow. Okay. So now we're going to move on to your treatment for those that are undergoing, radiation or cancer treatment, oncology treatments, and the impact that it has on the heart. Can you please talk about heart toxicity and how you treat that for those that are undergoing cancer treatment?
No, definitely. So that's I think a population that we all know suffer a lot with from the first time you hear you have cancer to the end, and those people are kind of facing a lot of chemotherapies or medications or new medications, sometimes that can cause toxicities in other places. One of the toxicities are heart toxicities, and they're well seen with chemotherapy related to breast cancer in women, and related also to lymphoma in men and women. So in the old days, you used to get the chemotherapy, and then your heart fails, and then you need to help your heart get back. You're already too late, and you need to, between now cancer and heart problem, makes your life very miserable. Nowadays, there is specialized in echo, a new modality, we call it cardiac strain. Strain meaning how's the muscle kind of able to generate power. And there is 3 types of strain. I will not go into detail of physics, but one type of strain now we can measure. In the old days, we cannot. And that strain is how the heart shorten itself to generate power and pump your blood. So that's the first thing that you lose with chemotherapy. So now what that advantage is that now you get chemotherapy. We have a certain protocol to measure that fiber strength or strain. And then we tell them, the fiber strength has been lost function. So that means in 3 months, if we leave you the same, your heart will fail. So now we can catch a cardiac injury before your heart fails by 3 months. And we can tell the oncologist or the cancer doctor, like, you need to decrease the chemotherapy or skip 1 session so you can get your cancer treatment and get rid of cancer. At the same time, your heart is able to maintain you all these times. So that's a breakthrough. We can measure strain on echo or MRI, and MRI is one of the most powerful tools that I'm specialized to. We call it one-stop shop, and also help us also in that field with cancer therapy.
So what recommendations do you have for those that are undergoing those type of cancer treatments, whether it's breast cancer or lymphoma cancer? For those patients, do you recommend that they come and see you or a doctor like you to, kind of have a parallel treatment track as they undergo radiation and treatment?
Definitely. Most big centers right now or building centers newly have what we call it cardio-oncology. It's a combination of oncology and cardiology, and now specialized people in both fields with working cardiologists and oncologists. And here in the area also, we're trying to form that coalition with oncologists to help the same time in parallel that we have that new technology to help people undergoing, especially breast cancer, as I said, undergo their survival and get rid of the cancer with a very good heart. And I had a very successful so far when I introduced that field here in the area, and we had a big survival, people who were heart recovered, or we caught it before it get worse, and their cancer is cured. So I think you need to work with the channels to get the oncologist to work with the cardiologist and have that program in place that will help you go through safe with chemotherapy or with other therapy, with your heart able to withstand that toxicity.
Right. So can you walk us through what that treatment looks like?
So the treatment kind of, let's say we find, a woman unfortunate, she had the breast cancer and they started chemotherapy. One of the chemotherapy that usually toxic to the heart called Herceptin, and people also know it as trastuzumab. But that medication or others can affect the heart and make it weak. So we do the ultrasound, we do some blood test or the echo with 2D and 3D and the strain that I mentioned, or an MRI, depending on the case. But let's say we start with an echo or an echocardiogram, and we find out that the heart is beginning to be affected. So, as I said, we decrease chemotherapy, and sometimes we put them on medication. There is a group of medication called ARB or beta blocker. Those have shown that will help the heart return or reverse that toxicity back to normal, and you catch it early. If you catch it early, it's reversible. If you catch it late, sometimes it becomes irreversible. So that's why that technology help us catch the people who are early toxicity rather than it's too late for them to reverse. So that's kind of the kind of a sample. It's a little bit more detailed, but kind of an overview of how we go through. And we follow them with every chemotherapy every 3 months, sometimes with an ultrasound of the heart and a strain.
Right. And so for those that maybe would not have been connected to a cardiologist, how would they know that they have heart toxicity? What are some of the symptoms, and how does the condition?
No, that's excellent. So the heart toxicity can be divided into, it's a big word, can be divided into heart failure, which is the most common, versus blockages in the heart or rhythm problem. But heart failure is the most common, and your symptoms are shortness of breath, fatigue, leg swollen, your leg became swollen, and sometimes chest pain, but mostly shortness of breath and fatigue are the main symptoms that start. So you used to walk a certain distance, now you walk half the distance, and you're huffing and puffing. That's one of the signs of heart failure, and you're gaining weight fast.
Okay, wow. Okay, so, I guess the only way to prevent heart toxicity is to see you and get treatment. That's what it sounds like. Is that the case?
Yeah, no, we work together for sure. We like anybody for sure. I like, as you mentioned, I like always to educate my patients and everybody in coming from a background that's all kind of academic and teaching. So I like to treat my patients to know their disease, as you mentioned, and especially people who are getting those kind of new therapies and all this new world that came to them with cancer. So it's a big deal. And if you put it on one of your family, you need to know what's going on and have some support and hope for the future that your heart will be okay and your cancer will be gone. And that's what we'll strive to help people to do that. And with those new technology, we're lucky to have this knowledge to help these conditions.
That's wonderful. Thank you so much for that. So as we look at cardiology in the more general view, can you please speak to the difference of how heart conditions present in women and men, and talk about, some of those warning signs and symptoms that we as women need to really pay attention to and make time to go and have evaluated and, checked out, and, versus men as well?
Definitely. If we talk about the number killer or the heart attack, or the disease of plaque buildup, we know that women have more heart attack, but men die more of heart attack. So, but women have more buildup of fat. So other also conditions that women also differentiate, and also we know muscle mass is different in the heart between men and women. Also a certain kind of volume, and now when we do an ultrasound to tell somebody that he has a normal heart, women is different than men. So like most people hear a percentage, how much my heart is pumping. So women have a certain number, and we say 54% to 70%. Men has 52% to 70%. So that's different kind of category. You need to look into different stages for every chamber in the heart or valve or measurements. Women are different than men if we talk anatomy. Now, if we talk with disease, multiple diseases, as I mentioned, the stiff heart is more in women than men. Middle-aged women and elderly women, especially with risk factor like diabetes or blood pressure or kidney disease, they have that condition much more than men. There is a condition also women have more than men that they need to know about. Some women have a lot of chest pain all the time, and they go to 1, 2, 3 specialists, and nobody knows why they continue having chest pain with multiple testing done. So there is something called microvascular angina, and it's more in women, or chronic pain syndrome, we call it. So a pain in the heart or pain in the chest that we don't know why, but it persists all the time. And now there is a new technology called PET scan. Before we didn't have it. We can measure the flow of the vessel inside your heart. And those tiny vessels, which we call them microvascular, sometimes they're diseased first before the big vessels. So in women, when you tell the woman we found that and we treat her with certain medication for that condition, on PET scan, it's night and day. Like no chest pain after 5 years of pain, that's a big deal. So that's kind of in a small time. I mean, I can talk for an hour about women health. We can, there's a specific for each disease, but that's like a little bit summary, kind of what we see between women and men in our cardiology field.
So in that specific treatment for women, how does that look like?
So if you're meaning the last condition I talked
Yes.
about. So the last condition I talked about, sometimes there's medication that makes those tiny vessels open up because you cannot fix them like the people know. You go and put a stent or open the heart, open the vessel. Those tiny vessels, they work with medication. You cannot go inside them. They're micromillimeters.
Right.
So there is a specific medications that open up. One of the medication called Ranexa. There is also the beta blockers, but there is a few medication. But the main problem with that condition is to diagnose it. That it goes unmissed all the time. The treatment is available, but most people are missed because they don't get those new technology testing.
So women that are experiencing that chest pain
that doesn't go away.
And it doesn't go away, they need to go see a cardiologist, even though maybe their primary care physician is dismissing it and telling them they have an otherwise, healthy heart. They may even say it's muscular, but the reality is it may be the
microvascular disease. And there is another condition also called myocardial bridging, but we can go into all these details. So there is a few conditions that can cause a chest pain and go unmissed if you don't know them and the right tool to use them. And I'm lucky that I'm specialized in multiple tools on imaging in cardiology, including the list that you mentioned. So that helps me go between like what's the rare disease or what that condition that keep on causing symptoms and undiagnosed.
Wow, that's wonderful. So let's go into another category of heart symptoms, and let's talk about heart failure, right? How can we know the cause, and what are the technologies and treatment options that you have available to treat?
Definitely. So we touched base a little bit before, but that opened up the field, as I said, of MRI. So cardiac MRI, if you go into communities, very, very rare people get cardiac MRI when needed because they don't have that resource in a hospital or in a place nearby because it's not yet disseminated knowledge in every specialist. So cardiac MRI, it's the only test in cardiology that tells you what we call it tissue characterization, meaning we can see inside the muscle like a fingerprint that tells us why the muscle is not working. Heart failure is equal to muscle not working or not pumping your blood that you need every time. So if we go into the muscle, we can open up the fingerprint and see what that damage and how it looks like inside, which no other test can tell us. With the MRI now, we can know rare diseases like a condition called amyloidosis, which is amyloidosis is a condition that a bad tissue that build up in your brain and heart and liver that can cause you dementia and heart failure. There is a condition called sarcoidosis, which is a chronic inflammation. You cannot diagnose it unless you do an MRI. There is a condition called myocarditis, which is a virus-induced, and COVID have been shown to cause 5 to 10% in young people. Myocarditis, which is an inflammation inside the heart, and you cannot diagnose that condition unless you do an MRI. An ultrasound cannot see it, or an echo or an old ultrasound that you do. So then there is with the heart failure genetic conditions that we know, or sometimes alcohol-related heart disease. Sometimes there is a very rare disease called Chagas, comes in South America and United States, that can affect the heart in a certain way. Plus your congenital disease, the holes, you're born with malformation. MRI is number one to diagnose with the sensitivity reaching 90 to 95%. So MRI is a big tool for people with heart failure to know the etiology of their condition, because unfortunately some people get the heart is failed and they tell them take this medication and that's it. But why your heart failed? Is it your cardiotoxicity from breast cancer? Is it all the other causes I mentioned? So MRI plays a big role, plus other testing to know the cause, so you can direct therapy to get the heart better. And that's, I think, a big step that you need to have in your treatment rather than only take medication without knowing why your heart failed.
So since we just went through COVID, myocarditis, like you said, is one of the side effects of people that have gone through COVID. Can you talk a little bit about what you've seen and how it is that we could know if, we are experiencing symptoms of myocarditis?
No, definitely. So what we've seen, and we've seen like kind of in the past few cases, hopefully, I'm glad that it wasn't a lot, but we found like kind of around 5 to 10% cases that were admitted to the hospital. We're talking not in general population, people who came to the hospital, and they came with a heart attack picture, even though they're age 40 or 30, and they don't have any risk factors to have heart attack. Now, first initial response by emergency room, they treat them as heart attack, and then they go inside to see if there is a blockage, and by their surprise, there's no blockage. That's most majority of them. And then when they consulted us as a specialist to come, and then we see that it's most likely he has COVID, he has symptoms of heart attack, he has heart failure. That's very typical of myocarditis. So we order that MRI, which we read and have this specific fingerprint, because myocarditis damage only the middle of the muscle in the heart. And people don't know that. It doesn't damage the proximity or the distal part of the muscle, only the middle in certain locations. And by certain criteria on MRI, we tell them this is myocarditis. So we know that condition. So we saw it 5 to 10% with COVID, and we're able to help a lot of people kind of recover their heart function because of that diagnosis.
Wow, that is remarkable. Thank you so much for your talent and for your dedication to our region to provide exceptional, cutting-edge heart treatment. Thank you so much, Dr. Samarany.
No, thank you a lot. Thank you for all of you, and thank you for your time. I appreciate it.
Thank you so much. And so for everyone listening, don't forget to look for us on Facebook, YouTube, LinkedIn, and Instagram. Check us out on scbrtalk.com, and don't forget to download the free live streaming app on Google Play or the Apple App Store. Don't miss my interview with Dr. Mike Stull, a professor of entrepreneurship, director of the Inland Empire Center for Entrepreneurship and the School of Entrepreneurship in the Jack H. Brown College of Business and Public Administration at California State University, San Bernardino. Under his leadership, the program has grown in stature and recognition, achieving multiple national and global awards. With nearly 40 years experience in business and education, Mike describes himself as the living example that entrepreneurship is a process that can be applied in any setting, and he truly thinks like an owner. Next week, we will have Sheriff Dicus. He is the sheriff of San Bernardino County. He was raised in a law enforcement family and has lived in San Bernardino County for over 40 years. In high school, he was a Sheriff's Explorer Scout. After graduating, he enlisted in the United States Army and was assigned to the 101st Airborne Division, where he served as a military police officer at Fort Campbell, Kentucky, in Sinai, Egypt. After his tour of service in the military, Sheriff Dicus worked for the Department of Veterans Affairs Police Department in Loma Linda, California. He was hired by the San Bernardino County Sheriff's Department in 1991 and attended the Frank Bland Training Center 106th Basic Academy session. Sheriff Dicus has a bachelor's degree in criminal justice from Cal State San Bernardino and a master's degree in communications from Cal Baptist University. As undersheriff, he oversaw the day-to-day operations of the department, as well as Internal Affairs Division, Civil Liabilities Division, and Bureau of Administration Division. One notable project was the Jail Utilization Study, done in partnership with Cal Forward to determine the effects of prison realignment and recidivism in San Bernardino County jails. As an assistant sheriff, he was responsible for support operations and supervised 3 deputy chiefs, the public affairs lieutenant, and the legislative liaison who oversaw the Corrections Bureau, Court Security, Crime Lab, Coroner, Employees Resources, Sheriff's Academy, Public Affairs, and local law enforcement legislative efforts. As a captain, Sheriff Dicus supervised technical services, communications, records, and the Bureau of Administration. Sheriff Dicus has held a position at every rank in the department, and his past assignments include corrections and patrol in Barstow, Apple Valley, Victor Valley stations. He worked specialized investigations in narcotics, SWAT, and criminal intelligence. Don't miss it, friends. See you next week.
Join Yvette Walker every Tuesday at 4 o'clock p.m. on KMET ABC News Radio, 1490 AM, FM 98.1, and Internet KMET TV for the Southern California Business Report. The show is dedicated to highlighting successful businesses and the individuals behind them. Yvette interviews the incredible people managing these enterprises that range from awe-inspiring sole proprietors to world-renowned organizations. The Southern California Business Report, Tuesdays at 4 o'clock p.m.